Let's start. Hi everyone. Today we have the webinar on the AVM. We have Professor Phạm Minh Thông, Dr. Trà Tân Hoành, Dr. Trần Minh Trí, and Dr. Nguyễn Đức Hiệp as a panelist. And we have two speakers. First, Dr. Nguyen Ngọc Cuong, and the second, Professor Ngô Mạnh Hùng. And I think maybe Nguyen Ngọc Cuong, can you start?
Yes, thank you very much, Professor He. Hi, everyone. This is the first time I participate in the group with neurosurgeon like this, and I initially at the beginning I thought that there are some young resident doctor from a neurosurgeon from Việt Đức, but I am quite surprised with the very respected professors and my teachers still here, and so I'm pleased to present to you the topic today related to the brain AVM embolization, and here my teachers, Professor Phạm Minh Thông, still here, and please give me some advice and some opinion or some correction about my presentation. And can you see my screen, share screen?
Yes.
Yeah. Okay, let's start. My name is Dr. Nguyễn Ngọc Cuong. I'm an interventional radiologist from Hà Nội Medical University Hospital, and I started to do brain AVM embolization since about 10 years ago with Professor Thông in my hospital. And today, what I talk to you today is like very basic about the endovascular embolization. Let's talk about the AVM, arteriovenous malformation. Is the abnormal combination between the arteries and the vein, as we see in the pictures here, without normal capillary bed. And this AVM include three components: the feeding arteries, the nidus, and the drainage vein. This is a very simple image that we can see in the textbook whenever you search about the AVM, not only the brain AVM, but also the peripheral AVM. On the AVM has three components like this. So today I would like to present the advantage related to the embolization. First is the diagnostics. The second is embolized materials and the strategies of embolization. Despite of the advantage in embolization materials and diagnostic imaging, the cure rate still remain very low, about 50%. So why the rate of the total occlusion is very low like this? Because of the difficulties of brain AVM embolization. First, I would like to present to you the classification of the AVM. This is the peripheral AVM, but we can apply it into the brain AVM because everywhere in the body, the AVM still can be classified in 4 types like this. The Taiwan is the fistula, the direct fistula between one arteries and the drainage vein. The Thai 2, we have some arteries, feeding arteries, and the nidus and the drainage vein. The Thai 3, the drainage vein dilated like this, and we can classify into type 3A, 3B, and type 4 AVM. With the type 1, the treatment is very easy and simple. We just occlude the feeding arteries by we can go through the arteries, and we put the coil or the glue, and we can occlude easily. But the second, the type 2, we have to go from the vein, or and then we occlude all the nidus by the glue, by the coil, or even by the absolute ethanol, or we can puncture directly into the nidus, and we also inject the embolic materials, and we cure the AVM. This is a type 2. And type 3 is easier. We just direct punctures into the dilated vein, and we occlude by the coil. And type 3B, we also direct punctures into the dilated vein, and then we occlude. So in conclusion of endovascular treatment of the AVM, we just go through the arterial access by Taiwan, and unfortunately, the Taiwan is very rare compared to the other. So almost of the AVM, we have to go through the vein and with all the direct punctures. But the difficulty of the brain AVM is not like that. The difficulties of brain AVM embolization, we cannot go by direct punctures, because we cannot puncture the needle through the bone. So we cannot go to by the vein. So only one way to embolize the brain AVM is going by the arterial way. So this is the difficult, because almost of the AVM has very complicated components with multiple feeding arteries. That is the first difficulties, and the second is we cannot occlude the normal vessels, the normal branch of arteries. Otherwise, we can we can make the infarction of the normal brain tissue, and can cause the complication. So that's why we have to combine with the surgery, radio surgery, with the large AVM. Yes, the small AVM is quite easy to treat by endovascular, but the medium and the large AVM we cannot treat only by endovascular embolization, except some simple AVM with 1 or 2 or 3 feeding arteries. We cannot do embolization totally by the endovascular way. So the most important of the AVM is the nidus. I think it is important with the interventional radiologist and also with the neurosurgeon, because only control the nidus or only do research the nidus the AVM can be cured. So the nidus is defined as the tortuous arteries go directly into the vein. That is the nidus. On the image, we must see the arteries, the drainage vein. That is when we see the nidus. Too early phase. If we see only the arteries without the drainage vein, that is we cannot see the nidus on the radio imaging. So the nidus here to depict the nidus, the most important imaging modality is the angiography, because angiography we can see like the real-time dynamic. We inject the contrast at the arterial phase, the early phase, and then we see the arteries and the drainage vein and the vein at the same time. That is the nidus. That is the nidus appearance. Yes. So there are some modality of imaging to diagnose the AVM, brain AVM, including the MRI, CTA, and the ESA. This is they are the classic modality that I think almost we almost know already. But I would like to show you some advantage in imaging modality. This we say the cone beam CT. This cone beam CT is combination of the angiography and CT scanner. Here we can we put the catheter into the left internal carotid arteries and we inject the contrast. And during injecting the contrast, the C-arm continue take the pictures. So we by that way we have the image as the dynamic image in multiple phase. Here we see only the arteries without the vein. Here we start to see some tiny nidus, and this phase we see the arteries and some nidus here, and here we don't see we don't see the vein. And this image we start to see the vein. With this image, this phase we have the nidus. We can define the nidus in this phase, and we can use this phase to analyze the feeding arteries and the component of the AVM and the drainage vein here. And with this phase is a little bit late because we see the dilated vein clearly, and this phase we see some small feeding arteries and almost of the drainage vein. And this is the last phase. This is drainage vein. See appears nicely here, but there are no feeding arteries to see. And this is a very late phase. So with this phase is very important because we see the arteries, we see the early vein appearance at the same time. So this is the nidus. And then we use this phase to see here. You can see this is the very optimal phase. We see the arteries, we see the nidus, and we also rotate. We also see some in very small slides, very thin slide to analyze the AVM. With this we can we say the dynamic cone CT angio. We also have the reconstruction in 3 dimension. For example, this brain AVM, we can combine the we put the catheter into the internal carotid arteries, and this the red colors here is the angiography from the vertebral arteries. With this image, we can combine in the same image as the 3D image, and we also rotate the image to see which is the artery, the feeding artery, which is the drainage vein, and where is the exact nidus. So with this imaging modality, we can analyze very well precisely the AVM, and we can also see the glue cast here, even we before injection of the glue. We can imagine the glue cast here if we inject the glue from the feeding arteries, and we can know the endpoint of the embolization. So this is a very good also for the not also for the interventional radiologists, but for the neurosurgeon too. Okay, so this is the other advantage in endovascular treatment. We have the new embolic agent, very good to use the glue for the brain AVM. With this glue, we can inject into the feeding arteries. You can see it go very deep into the nidus, like the lava of the volcano. It doesn't occlude at the beginning. You can see it can flow with the blood, and then after that, into 2 minutes, it can reflux and occlude the feeding arteries here, and we stop 2 minutes to polymerization of the glue, and then we can keep injecting. We can inject with this for a long time, for totally for 1 hour if the AVM is very big or very large. Here we can see the glue. The glue surround the tip of the microcatheters here. So the microcatheters can be glue into the vessels here. So that's why we have the other advantage in the microcatheter. The microcatheters here can be detached. This part, the blue part here, can stay into the brain AVM after we inject the glue. Why? Because the glue surrounds the tip of the microcatheter here, and then it can stuck the microcatheters, and we just withdraw the microcatheter. The blue one will stay into the brain AVM forever. This is very good to use for the brain AVM embolization. So the new strategies of brain AVM embolization is the transvenous embolization. As we see here, the multiple feeding arteries, we can occlude it by the balloon, and the other microcatheter will go for the vein, through the vein, and go into the AVM, and then we inject the glue. The glue will go to the nidus and go to the feeding arteries. By these methods, we can occlude totally the AVM. That is some advantage of innovation of the brain AVM treatment. So Speller-Martin classification, if the grade 1 or 2 is easy to treat even by the surgery or the embolization, but the grade 3, 4 is very difficult to treat totally. It's very challenging. So when to embolize the, so what is the indication of endovascular embolization? The common indication is pre-operative embolization, pre-radial surgery, or some small AVM. We have indication for curative embolization, or the big one, we have indication to do the palliative embolization. For example, the aneurysm in the nidus, we can occlude by embolization. So transvenous occlusion and ruptures. Okay, I would like to conclude in my presentation here. First, angiography is now very useful to display the nidus of the AVM, to have the interventional radiologist or the surgeon or the sclerotherapist to plan to do the treatment of AVM. And the new innovation in 3D angiography can have very useful to plan the treat the AVM. So endovascular embolization indication including curative or pre-operative embolization. Thank you very much for your attention. Thank you.
Okay, thank you very much, Dr. Cuong. It is very interesting and beautiful presentation. And the next speaker, I would like to invite Professor Nguyen. He will talk about the AVM treatment after Aruba study. Dr. Nguyen, please.
Thank you, Professor He and dear Professor Thong. Today, I would like to present my knowledge and experience about brain AVM surgery. I can show my. Yep. Everyone's see my screen?
Yes.
Okay. So, as previous mention of Dr. Cuong, we well know about the Speller-Martin classification for.
Hong, can you show full screen, please?
Yeah.
It's better, but it's okay. But it's better. Yeah, okay.
Okay. So as neurosurgeon, we well know the Spetzler-Martin classification for brain AVM, and I will re-mention the critique of Spetzler-Martin in the brain AVM. So we have three standards: the size, the location, and the Van der Waals for Spetzler-Martin classification. Before 2014, so for the rupture brain AVM, we do the surgery, we do the embolization and gamma knife radio surgery. Maybe some cases, but we have a lot of questions about the unruptured brain AVM. When, why, and how we do treatment. And at the year 2014, Aruba is medical management with or without interventional therapy for unruptured brain arteriovenous malformation. Published in Lancet, change a lot of strategy of treatment of the brain AVM. So Aruba study is the first prospective randomized trial, and this study compare as a studies the unruptured brain AVM and divide into group. Group one, the medical treatment is mean observation and seizure treatment, for example, and group two is the intervention, surgery, embolization, and radio surgery. And in the 2014, when the author published in Lancet in the interim analysis, they found the medical management is better, the medical management make better outcome compare intervention treatment. It means the less mobility and less mortality. After that, there were a lot of critics to the Aruba study. For example, study design is not good. The follow-up period was short, and in the group of interventional treatment is no standardized AVM treatment. So I would like to overview the Aruba and effects of this study on the AVM brain AVM's microsurgery. So Aruba is a study is the first study multi-central prospective randomized, and this study evaluation the outcome between the medical management versus the treatment of unruptured brain AVM. in the first time of the Aruba, they would like to follow up in 12 years with with two primary endpoints: the rate of death and the rate of symptomatic shock after follow up the brain AVM. And the patient is randomized in the treatment arm and the medical arm. And in the treatment group, the decision of treatment, the methods of decision method will decide by the personal expertise. And the result, they had 40 patients were screened for study, but only 30% were randomized. And after 33 months follow-up, they take the interim analyzer, and they found the medical treatment, medical management is better than the interventional treatment. So the randomized was stopped because of the result. And after that, they follow up the patient, and the final analysis in 2020, they take the result with the same result in 2040. But Aruba's study faced too many criticism. First, the selection bias, and the lack of treatment standardization, the low rate of enrollment, the follow-up time is very short, and the lack of subgroup analysis. In the definition of primary endpoint, for example, symptomatic shock is inappropriate. After Aruba study, there are a lot of study to take the evidence against the result of Aruba. For example, in the same year of Aruba study, Rothschild and college published in Neurosurgery Focus, a retrospective study with 74 Aruba eligible patients. And in the study, they had 30 observation and 61 intervention. Almost this of those was microsurgery. And with identification Aruba endpoint, they found no significant difference between the observation and interventional group. And after that, in 2015, NEVRA published a retrospective study with 61 Aruba patients, and the author stratified by special Martin rate, and they found a functional outcome similar to the medical Aruba. So the surgery of grade 1 and 2 of Bachelor Martin make the result similar to the medical arm of Aruba study. After that, in 2017, Young and college published 155 Aruba eligible patient of surgery, microsurgery, and they found the neurologic disability is better than Aruba study. The same year, Lebras Swam published the result of the analysis of 2088 patient classification in Bachelor Martin, and they published the result, the high obliteration rate, and no, they don't find the increased complication. Nearly Papuli 2019 follow-up 12-year experience of Aruba eligible patients, and they found the rate of post-operative shock lower than interventional arm of Aruba. And almost Aruba's post-Aruba study has some weak and strong and strong evidence. The weak power is almost all of study after Aruba study is retrospective and single center, but they found that consistently demonstrate better outcome than those of Aruba study. And after Aruba study trends in brain AVM treatments, Komasu and college 2020 published the trends of treatment strategy over time for arterial brain AVM in Japan, and they found a significant decline in microsurgery, but concurrent increase in radiotherapy, radiosurgery. The same in 2021, microsurgery declines and radiosurgery and endovascular treatment no change between before and after Aruba study. And Lotho in 2022 found present the decline of microsurgery before and after to Aruba study. So we can see the decrease of the number of brain AVM surgery after Aruba study. And here the open surgery is a decrease, but embolization and is no change. And our result published in 2019 in Vietnam, we have the same result between in our study and the in international standards. And conclusions microsurgery still an effective treatment of unruptured AVM, as Dr. Cuong mentioned before. I think brain AVM class 1, 2 can do surgery, and class 3 we can combine microsurgery and embolization. Thank you for attention. Hello.
Hello, why don't I? Hi. May I have a question and some comment about the treatment of AVM?
Yeah.
Okay. So
I'm sorry, I can stop so much. Yeah.
no problem. Yeah, so I have some comment only because Aruba after Aruba there are many research about the treatment of AVM for neurosurgery, microsurgery, and embolization too. For the material, for the devices in interventional neuroradiology, they have many advances. So as microcatheter, small microcatheter, and small guide wire, and some other. So for rupture, no, the most important is for how we educate the patient. AVM, rupture AVM, okay, we have to treat it, but non-rupture AVM, how to treat it. So we follow many conferences in interventional neuroradiology. They show that we should treat non-rupture AVM if the small AVM and AVM is when AVM has the risk of rupture. When AVM has a risk of rupture, you have to treat it. The AVM is small AVM with aneurysm is a feeder. Is the feeder of artery feeding and some other. So we should treat. If non-rupture but have no complication and no risk of rupture, we don't need to treat it and follow up the patient, especially for big AVM, sphenomartin 3, 4, we have to follow and don't need to treat it. I think, but it depends. But it depends on it depends on experiences of the team, because of many big team or good team combine surgery and embolization. They should treat unruptured AVM, sputum 3. But for big 4, 5, don't need to treat it. Very dangerous. Only 1, 2, 3. Okay, should treat. Okay, I have some comment like that. But for 1, 2, stage 1, 2, sputum, you should do surgery or embolization. If surgery is easy, do surgery. If in deep position, so embolization is better. If very superficial, we should do surgery, better surgery, and very deep, and in the functional location. So it's difficult for surgery. It should do embolization, just like that, and have some small comment like that. Thank you.
Okay, thank you, Professor Phạm Minh Thông. Yes, I would like to invite Dr. Chatan Hoang. Dr. Hoang, please. Do you have some comment or question? Please.
Yes. Keep Professor Sahe. First of all, I would like to thank the two very great presentation of the two speak speaker, Dr. Cuong and Professor Hong. I know that now it's very a lot of event in the intervascular intervention, like Professor Hong said. I consider that I know that if we until now we have the four modality to treatment of the AVM, surgery, embolization, radiotherapy, and four we combine all of these methods to treatment the AVM. So until now, like Professor Lawton said, very few patients can treatment. Very few patients with AVM can treatment by one modality. It means, for example, for embolization, the proportion of the patient get have a treatment a lot with embolization along about less than 10%. I don't know now how to improve, but in the past it was about 10%, and the proportion of the completely like we can treat along with the embolization along with very not high the ratio of successful and but now I have question for the Dr. Cuong and Professor Tom is now with the new agent of embolic agent. I would I would not I would like to I have question that now the proportion of the patient have a treatment with the embolization along is increase or changing recently or not, and about the presentation of the Professor Hong. I read the Aruba study, but I think in Vietnam the Aruba is not effective. In more of the center of the neurosurgery in Vietnam, we do it the same. We do, I think, the same before and after surgery, before and after Aruba study in our world. A lot of things change before and after the Aruba study. For example, like Professor Hong said about the number of the patient getting to the hospital, the number of the patient have a surgery, especially for the patient in rupture AVM. But and at the Dr. Professor Hong said, the Aruba study, it had a lot of limit, and even Aruba study get a lot out of fires, racism. It means a lot of surgeon, a lot of intervention doctor in other words, they don't agree with the Aruba study, and after that a lot of the study has been published, and they saw that the outcome and the result with the treatment with the IVM and WRM have a good outcome with the less complication. Yeah. Thank you.
For intervention, so now it's a new material. The breadth of total occlusion of AVM of the nidus very high. It now more than 60%. It's not 10% like before. And now the rest up to 60, 70%. It depends. If the nidus is small AVM, fragmented 2 with 1, 2 is very effective. But for big, now you have to combine Yeah, the other embolization and then surgery or radio surgery. So, but it depends also the team, because in France, the team of Jacques Murray, they do embolize for rather big AVM, but almost few obligations of all AVM, because it do many times and then go by artery feeder, artery way approach, and then venous approach, and combine many techniques to do it, but it's dangerous too. So for us, for our hospital, we do only embolization for small AVM, and then for big AVM, big AVM, you combine for unrupture with risk only. If no risk, don't do it. Don't embolize. Don't do anything. Follow up. Yeah, because it's dangerous. For spending my time 4, 5, don't touch it. Very, very dangerous. Thank you.
Thank you very much, Professor Tong. And next, I would like to invite Dr. Chi. Dr. Chi, please.
Thank Professor Hai for inviting me. Thank you, Dr. Cuong and Professor Hung for your presentation. This time you present a very interesting topic and look through literature review. We talk about unruptured AVM. For unruptured AVM, as Professor Tom said, for splenomegaly 4 and 5, we better don't touch it. And we discuss about a splenomegaly 1 or 2 or 3. Look all the data on, we can see whether patient come to us with unruptured AVM with splenomegaly 1 or 2. What we could do, what's the best choice for this patient, and for surgery, the risk of surgery, mortality and morbidity is high, more than 10%. And for radiosurgery, it's nearly 10%. But for radiosurgery, we need a long time to follow up and see obliteration rates. It takes from 5 to 6, even 9 years on some paper they publish this. But for surgery, we have a very risk outcome for splenomegaly 1 or 2, it's nearly 90% to 100%. What we should do for patient? Some paper that published, like Dr. Lawton, they choose surgery for the first line in patient with splenomegaly 1 or 2. But some meta-analysis, they choose radiosurgery. And I think that radiosurgery can play a very important role for treatment patients with splenomegaly 1 and 2 because it's low complication and obliteration rate is high. It's nearly 95%. And for splenomegaly 3, it's difficult. Sometimes we need endovascular surgeon to embolize that, and then we follow up with surgery, either surgery or radiosurgery. I think and many, as Dr. Huan and Professor Tom said before, Aruba trial have many limited you said before, radiosurgery have a very long-term result. We need to follow up very long time. But for surgery, the complication come very early. Some people, they say that they look at complication of surgery straight away after surgery. They think surgery may have a high risk of mortality and morbidity. It different viewpoint. Some doctor want to do surgery for sphleromatine 1 or 2, with the other 2 radiosurgery. But in my viewpoint, in our hospital right now, for sphleromatine 1 or 2, we prefer patient for radiosurgery than we do surgery. We often do surgery for rupture AVM than unrupture AVM. Thank you.
Okay, thank you very much, Dr. Chi. And next, I would like to invite Dr. Hiệp. Dr. Hiệp, please.
Yes, thank you for having me here. Today is third sessions about AVM, and you have almost our experts in different techniques for treatment of AVM. And you have today 2 presentation about embolization technique and treatment and management for AVM, and the chain after chain of management of AVM after Aruba study. So for first presentation, I have some comments because the embolization is now is maybe is evaluated like mini-invasive technique for intervention for AVM after surgery and radiosurgery. I say that because obviously embolization is revolution. Have a revolution year after year. You have many techniques. You have a new agent for embolization. You have new technique like microcatheter, balloon assist, venous embolization, like showed in a slide. And but you can do for embolization. You have 4 approach. The first is pre-surgical embolization approach. The second is a pre-radiosurgery approach, and the third, palliative surgery, palliative treatment, and the fourth, curative, like Dr. Cuong had said in slide. And the curative is also is very effective for AVM of grade 1 and 2 and less than 3 centimeters. And a report newly evaluates that for AVM less than 3 centimeters, embolization can be effective 5 times than AVM more than 3 centimeter. So for small AVM, you can choose between surgery and embolization. Is like the same. It's not first line because, for example, Professor Lawton he's a surgeon. He choose surgery, but AVM is a mini-invasive approach. So for small AVM, you can use embolization. And so now we know all that is a multimodality, multidisciplinary approach for treatment of AVM. So you have 4 approach, like I said earlier. The first is pre-surgical embolization. The second, the pre-radiosurgery embolization, and 3 is pre-radiosurgery surgery. I'm sorry, pre-surgery stereotactic radiosurgery, and 4th is multiple. So that you have choose. You can do all 3 main approach, main treatment in the same patient. So how you choose this approach, because you have to you know that the choice of treatment is have many the wide variation depend on center in around the world. So in Vietnam, you think you can have meeting between disciplinary for treatment in the complex AVM. And I have 2 questions for presenter Dr. Cuong, but maybe he did not yet here, but he can answer later. That means the first thing is for do he have a difference for AVM of posterior fossa? Because it's sometimes did he have any difference between the AVM of anterior anterior fossa and posterior fossa AVM? Because they sometimes difference. And the second, and for pediatric patient, and in pediatrics patient is sometimes it's very difficult to discover. And now after with CT scan around in the almost hospital, you have you can discover many cases of AVM in children. So having treated for pediatric AVM, and have you any differences between 2 group of patients? And for second presentation, I want to talk clearly, more clear about Aruba study. The critique about Aruba, like the previous seance I talked is study about unruptured AVM, and the critique, the conclusion of the study, that means the medical treatment is better than medical treatment with intervention. So obviously they receive many critique because that means you didn't have to any intervention to AVM once you can discover in the normal patient, for example. So the critique have three main points. The first is site selection. Site selection because for is the study is no blind. So the seat selection and the recruitment and outcome measure is different. And the third is the length of follow-up. They have only about 45 months. 33 months. So it's about 3 years. It's not many. So after that, you can think you can predict that there will many study in the can follow that the main reason, the main approach of study to decide what you will do with unruptured AVM, especially for for small AVM, grade 1, grade 2, even grade 3. So for grade 4 and for grade 5, yes, you can think you don't touch it's better. But for grade 1 and grade 2, especially grade 1 and grade 3. So I think in the you can treat with our treatment approach like a surgery embolization with small AVM, and from grade 3 or 4 and 5 you can for grade 3 you can discuss, and for grade 4 and grade 5 is monitoring. Yes, follow up. Yes, it's finished. Thank you.
Thank you very much, Dr. Hiệp. And Dr. Hung, can you do you have some comment or?
Yes, I think you were Professor. I totally agree to Professor Thong and Dr. Chi. In Vietnam Hospital, we use microsurgery for the unruptured brain AVM GAT 1 and GAT 2. In my experience, I will take surgery alone, but GAT 3, some cases it depends on the brain AVM. But if they have to indicated of treatment, I will take the embolization before operation. So I take the embolization. I take the patient embolization the day in the morning, and I will operate in the afternoon. And what unruptured brain AVM we should treatment. I totally agree with the Professor Thong. If the brain AVM has aneurysm in the nidus and the structure of brain AVM, for example, is there a little or small vein, maybe we will take the treatment. But I found the brain AVM is very difficult to decision if operate of treatment or not, and it depends. I think the treatment decision must be individual. Thank you.
Okay, thank you very much, Dr. Hung.
I think the indications for treatment of small AVM depend on many things. Firstly, for position, it's easy. It's superficial, so it should do the surgery very easy. So it depends each patient, but very important, it's easy to do it. For surgery or for ablation, it depends. That's why you have to look and check very carefully the AVM, small AVM, and discuss between neurosurgeon and radiologists and neuroradiologists to decide what do you do it for the patient, do the best for the patient. Sometimes we don't do anything. If with a small AVM, but don't do anything. If not rest, if very deep, in deep position, maybe various surgery better. Yes, some small. In Europe now, they do many cases with various surgery. With various surgery for small AVM, superficial surgery, and sometimes ablation. It depends. But rupture, okay, do it. But unrupture, discuss. Unrupture, discuss case by case. Thank you.
Yes, and yeah, please, I want a comment. Yes, I agree with the Professor Thong about that. With small AVM in superficial, you have do surgery, and for the deep AVM, you can discuss for embolization. But I have one fact to do because AVM is not fixed. It's not. It can be evaluated. It can be bigger, and it can be can cause many symptoms, and normally with headache and epilepsy is a special cases. But for deep AVM, the exploration, clinic exploration, need to be monitor strictly by a neurologist, because there are many symptoms. For example, the symptom with AVM in the thalamus, for example, they can have symptoms, but it's not easy to discover. I think in that case, you have you need to a neurologist who follow the patient for in the a long time to discover if they have new symptom or set up to to start up symptoms or not, because very difficult to exploring the symptoms, clinical symptoms in the patient. Sometimes they have to do electronics exploration for discover if they and many other method of exploration. So I think if they think you have to follow the patient, follow up in the, sometimes you need a neurologist to do that. Yes, that's all.
Okay, thank you very much, Dr. Hiệp. And I have a question for everybody. Do you have some experience for the surgery to remove the AVM after embolization? Some people say the embolization before surgeries. It may have something for the surgeon, but somebody says that it's not easy, but sometimes it's more complicated. Do you have some experience about that? You can do sometimes surgery after embolization.
Hi, Professor. May I ask Professor Thong? As Dr. Cuong presented before, in some AVM, he do transvenous embolization. Do you often do that? In my viewpoint, when I do surgery for dissecting AVM, the main point is preserve renin vein until the end of surgery. We have to protect renin vein very carefully. Whenever you dissect and sacrifice all the feeding artery, and the last step is we sacrifice renin vein. However, if neuroradiologists, they do transvenous embolization, they go through the vein and they may sacrifice the renin vein. Then this procedure will be end, because when we damage the renin vein, the whole nidus will be ruptured.
Yeah.
Yeah.
So for venous approach is very few. We don't use for many cases. So it depends. But sometimes when you go by arterial approach, you cannot go by arterial approach. You can go by venous approach. That means you introduce the microcatheter inside the nidus by venous approach, and you have to embolize totally the nidus. That means small AVM. And normally we have to go by arterial approach, and then do the embolization. And if you cannot ablate totally the small AVM by arterial approach, you can go other by venous approach, and then embolize totally AVM. You have to check, and then you embolize the vein. So you have to embolize totally. if you don't embolize totally the AVM, the risk rupture very high. So you have to embolize totally. So the venereal approach is not common. Indication for some cases only, not very common. Yeah, sometimes you have to do it, but not common. Sometimes you cannot, the small AVM, you cannot go by arterial, but by venereal approach, you can go by and curative treatment by venereal approach. Yeah. And for children, an AVM of children and adults, some different. For technically, more difficult for children. And the kinds of AVM is different. And in children, more fistula than AVM, and some experiences in Children's Hospital, Dr. Cuong in Children's Hospital. He learned from Bajmai, and then he do a lot of cases in Children's Hospital. And in Bajmai, we have not many cases of children AVM for children, but technically the same like for adult. And for posterior fossa AVM and anterior fossa AVM, there are many different of treatment. Ablation is the same technique. It's not many different. It's the posterior fossa and anterior fossa AVM treatment by embolization, but not many cases. Thank you.
Okay, thank you very much, Professor Thong and Dr. Chi. Do you have some comment or questions?
Yeah,
Yes, please.
yeah, with the children and elders, IVM. I think the not different about the technique, but in children the more difficult than the elders. That's natural because the structure of the vascular of the children very small and everything more difficult than in elders. But the concept treatment is different. It's very different in the concept with the AVM in pediatric because some reason. The first one is the children come with the more frequent clinical with hemorrhage, about 80% cases, and because intubation the ratio of the bleeding is higher than others, and also in the group of the children also have more with a higher morbidity and mortality, and the patient and pediatric patient also have a longer life expectancy. So it means they need a little bit more aggressive treatment than in others. And some authors say that even with the asymptomatic, it means the unruptured IVM, of course, before we make a decision, the treatment, we have to balance the risk and the benefit for the patient, because the patient have a very long time to live. And we have discussed with the family, discussed with our team, and we have, but the pediatric AVM needs more aggressive treatment than other patient. And with the question of the hip, what are different in the AVM in posterior fossa and super and supratentorial fossa, because they in the posterior fossa the ratio of bleeding is a little bit higher, and we have separated two type AVM in the hemisphere of the cerebellar and AVM of brainstem is quite different. If the brainstem, then the first choice is the radio surgery, but for the cerebellar, the first choice is the surgery, and also the AVM in the posterior fossa, especially in the AVM in the hemisphere of the cerebellar. Surgery have number one role in the treatment center. Thank you.
Okay, thank you very much, Dr. Hoang.
I have a comment, please. Thank you, Professor Thong and Dr. Hoang answer my question. But I have a new topic I want to discuss, but maybe not today. Is AVM in spinal cord. It's very difficult subject because it's not rare, but sometimes it's very difficult to visualization about treatment. And I hope one day you have a discussion about this topic. Thank you.
Okay, thank you very much, Dr. Hiệp. Do you think we have some improvement in the treatment of AVM in grade 3? Because everybody knows that for the grade 4 and grade 5, we have no change from decades in the strategy of treatment of AVM. But for the grade 3, do we have some improvement?
I think you have some improvement because now for the devices, for the material, we use for embolization where tray is preoperative embolization. So we should do embolization with very small microcatheter and very new technique in embolization. So we should do for wet tray and then preoperative AVM treatment. So I think it should do more because it's honest and it's other agent new. So we should do the embolization for wet tray or 40% of AVM or some feeder and some deep feeder like that. So I think some advances in treatment of with tray. Thank you.
Yeah, thank you very much, Professor Thong. And how about the other doctor?
I think we have some improvement of surgery of last 3 brain AVM. But I think the improvement come from the advantage of material in microsurgery. For example, bipolar. For example, the microscope and and some products to hemostats. Come back to comment and question of Professor He about the pre-operative embolization for brain AVM, for example, for grade 3 brain AVMs. I have some experience about the patients who had pre-operative embolization, and sometimes I found it's very difficult to resect the AVM, the nidus, because of the embolytic agent in the brain AVM, make the brain AVM is so solid. Is like brain tumor, but we can debug, and very difficult to dissect. And after that, I declined indicate embolization before operation. Of course, if we don't embolization, we have to face to the risk of high blood disk in surgery. But if we dissect and coagulate slowly, we can so the size of AVM will be decreased with the coagulate the brain AVM. So I have some comment like this. Thank you.
Okay, thank you very much, Dr. Hung. And how about Dr. Huang and Dr. Chi? Do you experience the same?
For splenomegaly red 3, it depends on what's the size of the nidus. For example, put red 3 is a nidus bigger than 6 cm in non-eloquent area, we can do surgery straight away. What we can do embolization before surgery is some AVM with many feeding artery, especially the feeding artery from the deep size, for example, is from PCA. With many feeding artery in the deep feeding artery, to avoid blood loss, we better offer embolization before surgery. And for the AVM, if we see we can control the feeding artery around the new nidus, we can do straight away. We used to do many big AVM in my hospital, so we before surgery we will do 4 angiogram, and we must think and find how many feeding artery come from where, and we plan ahead in our brain. Recently, we have a navigation system. We better use navigation system to identify the border of nidus, and we dissect around the nidus in order to avoid the damaged brain tissue. And we look for feeding artery. It's a best choice. It's a best choice if we have a mini clip when we do when we operate AVM. Sometimes we have mini clip. We use this during surgery, but recently we don't have a mini clip anymore. So when we find feeding artery, we sacrifice straight away. How about in the hospital? You have mini clip to do AVM.
Yes, and you know that sometimes it's not easy to buy because it's very complicated to ask every company to get a mini clip. And Dr. G, do you have experience to remove the AVM after embolization?
Yeah, it's not very common. In some difficult case, we rarely do embolization before surgery. In special case, and I talked before, some case when I find many deep feeding artery, and then we offer for embolization before that. But for embolization, I think when we do embolization, sometimes the needle will be screened, and if very solid, when we cut it, we go around and cut it. But if we do it, we can sacrifice feeding artery easier.
Okay, thank you very much, Dr. Chi. And how about Dr. Hoang?
About the other professor had a question about the advance in our treatment AVM poetry. First, like Dr. Tree said, royalty they have now with the Spatler, Martin, and Lawton in 2002. In royalty, we have 4 subtips. In some subtips, with for example, with the big side of the AVM, but no eloquent, no deep drainage vent. It's easy. It's easy, and another kind of the tip tree, for example, the medium, just small one AVM, but in a local and have a deep vent. Totally, we have a glass tree, but I think it's not the same. So I would say that in the classification Spatler, Martin, and Lawton and Young, we have in Grati, they have the 4 subtips, and some subtips are easy to surgery and some subtips very difficult, including the Grati. And the second one is now we have a lot of advanced in technique, like new microscope. We can dive the lesion, we can find out early of feeding artery, and we can imagine the structure of the AVM before we work the beginning of ejection. So it helps us a lot. And about the experience of remove the AVM after the embolization, in recently I usually perform the surgery AVM after the embolization in the most case, especially in the big case. At the beginning, we feel it's not comfortable, but I think the benefit from the embolization before surgery much bigger than yet, and it helps to easily check and help to kill the feeding artery from the opposite side and the deep side first. So I think it, and then also help to avoid the complication like edema or bleeding after the surgery before we remove it very big AVM. Yeah. Thank you.
Okay, thank you very much, Dr. Hoang. Do you have more question?
I have a question for Professor Thong. Yeah.
Yes, please.
And yes, now it's combine the embolization and surgery is very common, and it get I think the more common in combined mortality in treatment AVM. So, but with the Professor Thong can share with us the experiences how to embolization before the surgery with the high effect. Yeah.
In my hospital, we have a whole relationship with the neurosurgery department. So for the big AVM work trade, so we discuss how to do the embolization, which feeder they need to embolize, and then do the embolization to some leader, some feeder, and then they do the surgery the day after. That's so that Dr. Chang do a lot. Dr. Chang from Bạch she do the thesis or PhD thesis, AVM treatment combine embolization and preoperative embolization and then surgery. So the result is rather good. I looked at that, but in many cases, preoperative embolization and then surgery the day after. Yeah, she has more than 100 cases in her thesis, like that. Yes, and now for small, okay, depend, but for big, always preoperative embolization and then surgery. But we have discussed before doing the embolization.
May I ask you, Professor Thom, and you told Dr. Trang they did more than 60 AVM with embolization before surgery?
I don't know how many, but a lot of cases. The thesis.
So far, you have a high number of embolization before surgery. So far, do you have any complication when you do embolization?
Yes, of course.
For AVM?
Yes, sometimes complication. Some hemorrhage complication. Yeah, because of a big AVM, if you embolize a lot of the volume of AVM, if you embolize more, so the risk of rupture is very high. So for big, we embolize only a little, 30%, maximum 40% of the volume of the AVM, not many. If many, if it's risk of rupture. We embolize only for preoperative. We embolize only the feeder, not go very far to the nidus. The nidus not many, only 30, 40 maximum, the volume of AVM.
So in your viewpoint, when you do embolization for AVM before surgery, how often, how many feeding artery you try to embolize that, or you embolize with many big feeding artery, or you try as much as possible, you embolize all the feeding artery?
No, it depends. We embolize all these deep feeder, and the feeder is difficult for resection. So not all the feeder. Because if you embolize all the feeder, the risk rupture very high. So we operate only the deep or the difficult for resection for surgery only.
Yeah, thank you.
I have a question for Professor Hong. So the timing you perform the surgery after the embolization, you said you did the embolization in the morning and perform the surgery in the afternoon. That's
Yep.
right.
Yeah.
So we do usually a little bit different. I do surgery before the embolization about 1 week. Yeah. How do you think about that?
Yes, I have a same question with like you because of each brain AVM. I would like to embolizate before surgery. I don't like totally take the embolization. So I talked about the radiologist make the embolization partial. Yeah. So to decrease the size of the brain AVM for operate, not for so pure embolization. So the high risk, like Professor Thong said before, if we take the partial embolization of brain AVM, the patient has a more high risk of bleeding. So I think the and I take the same question, like Dr. Huang to one professor in Japan, and he told me he take the embolization in the morning and he take surgery in the afternoon, and after that I do like him.
Long
Thank you,
time
Dr. Hong.
ago, yeah. Long time ago, when neuroradiologists do embolization for AVM, they often use glue, and they ask neurosurgeon to do surgery in 2 or 3 days. But recently, they use different material like onyx.
Yeah.
When we do embolization, and we can do whenever we want, but we don't do quite urgent like Professor Hong. So 2 or 3 days later, we put patient in elective case and we do surgery. So it depends on surgeon. You see, whenever they feel confident to do that.
But
Yeah.
the less and less I do the embolization before operation, the less and less. And come back to the question of Professor Dr. Chi about milliclip. In my cases, I rarely use a milliclip for brain AVM. I rarely. I have some milliclip. From the gift of my professor, but I don't. I rarely use my milliclip for that. Maybe I take the temporal clip to clip the big vessel, and after that I coagulate the big artery, the big artery to go to the lidus, and after that I remove temporal clip. So I never maybe because of I don't have enough melee clip, so I don't so habit. I don't have a habit to use a metal clip for the brain AVM.
Does that mean we have to use many clips, right? So now for new material, for honest, so we should, the honest go very far inside the nidus and go to small branches of AVM. It's not only the feeder, but from the feeder, but go inside the nidus and go far to the small artery. So it become maybe SEC is operation SEC operation, right? It's like for embolization of melanoma. Melanoma is big melanoma. We should do the embolization and then surgery is better than surgery alone. Yeah, for the big melanoma, and AVM is like that. But for AVM, and now always use new material, not the glue, and that's onyx and other like onyx. Yeah.
I would like to talk about the pre-surgical embolizations. That's Dr. Thong talk about the theory in the Bạch Mai Hospital. I read this paper and the thesis of Dr. Chang, and in this paper, she's talk about the advantage of pre-surgical embolization in the case of AVM, and she's talk it is very, very useful, and everything is good in case of pre-surgical embolization. But in the literature, you can find many paper. They have talk about the preoperative embolization of brain AVM, and this is a controversial strategy. And you can see, I can get one paper. It is a systematic review and meta-analysis. It's published last year, 2022, and the conclusions, it is a meta-analysis. The conclusion is based on the published literature. There is currently insufficient evidence to recommend pre-operative embolization of brain AVM. This is conclusions. And I have invited Professor Michael Lawton. I think many Vietnamese neurosurgeons know Professor Michael Morgan. He's come from Sydney, and he's participate in our meeting sometime, and he's give lecture in our hospital. I think the last time is maybe nearly 10 years ago, and he don't like to make pre-surgical embolization for AVM surgery. And he's joking. 1 week ago, the doctor put one Mercedes car in the brain, and 1 week later, we tried to remove the Mercedes car. And I have not too many experience, but I do. I have the same experience with Dr. Hung. I have some, I do some surgery after embolization, I tried to remove the AVM, but it's really hard. It's not easy to remove the AVM. It is so hard. We cannot easily to go around the AVM. It's really hard. And in the end, I think maybe we make more lesion around the AVM when we try to remove the AVM. It is really hard. It's not easy. And these are things I know about the preoperative embolization for AVM. And now I do sometimes the preoperative embolization for AVM, but not systematically. It's not systematically. Sometimes when you choose it, it's very difficult. Maybe it's bleeding or something like that. And that's all. Thank you very much. Do you have some more question or comment about the AVM?
Yeah, I would say any procedure always carry on the risk. For example, for embolization, when you do phonogram or when you do embolization, it's invasive technique. It's carry on the risk of procedure. Moreover, when you do embolization for AVM, you may change the flow. The aneurysm may rupture after embolization. You look through the literature review, we can see that kind of complication. So if very necessary to do embolization before AVM, we should do. However, if we confident enough to sacrifice the feeding artery, we go ahead for surgery. We don't need to do embolization before surgery. We may avoid some complication because of embolization. And you look on literature review, right? For some many years ago, when you look on the paper, you see for big or giant meningioma, they sometimes recommend for embolization before removing the tumor. But recently, they don't do it before. They don't do embolization before removing big meningioma like that. So we think about that. If we think it's necessary, that go ahead. Otherwise, we can do surgery straight away. Thank you.
Thank you very much. Okay. Some more question or comment?
I think the AVM treatment is very hard. Is my opinion. It depends. Yeah, it depends of team. Yes, for the treatment. But sometimes the combination, the combined surgery and embolization, I think sometimes it's a good idea. It depends on case by case. It depends on the experiences of the surgery. If with a good surgeon, neurosurgeon with good all the equipment, so yeah, everything can be done very well. But for other, yeah, it depends on experience. It depends of the idea of a surgeon, of biologist. If you have good neurobiologist, if we have a good interventionist with a good surgeon, discuss and so do the best for the patient. Yeah, the final target is to do the best for the patient. Not for us.
Yeah, thank you very much, Professor Tong. It is really, really hard for the AVM treatment. It's not clear like aneurysm. Aneurysm is more easily to make a strategy. Of course, some complicated aneurysm is it's bad. Yeah, but AVM is very different.
Yes, yes.
Yeah.
Sometimes the research, sometimes evidence not the, sometimes the trial not the results not good, but they have to do more and more trial.
Yeah.
It's like the stroke treatment. It's like stroke thrombectomy. For a long time, just to go up to 2015, the result good. The trials of thrombectomy for everywhere, the thrombectomy is good with the trial. Many trials is good result. And then after that, thrombectomy can do anywhere. And the time window, not 6 hours, but now time window is 24 hours, not 6 hours. It depends. So that means the research, we have to do more and more research because everything changed. Thank you.
Yeah. Thank you very much. You have some more questions? If you don't have, I close this webinar tonight. Okay. Okay. On behalf of organizing committee, I would like to say many thanks to Professor Tong, to Dr. Chi, Dr. Cha Tân Hoành, and Dr. Hiệp. Especially many thanks to Dr. Cuong and Professor Hung. Thank you, everybody. See you next time. Bye bye.
Thank you. Bye.
Bye.